So you're dispatched for a male in their 30s who is at home, who is also on a ventilator because they have low SpO2 levels. What do you do? Hi, my name's Aaron, and I work with Ross Training Academy, and I'm also a full-time firefighter paramedic. And while maintaining my full-time 911 career, I've also worked in ERs and on transport units, where I've learned to maintain and set up patients with RSI, DSI, and putting them onto ventilators or maintaining their ventilator. And so today, we're just going to go ahead and talk about basic ventilator management so you know what to do when that call comes. All right, so we're going to go ahead and start looking at basic ventilator management. So when should you use a ventilator? You're going to start using a ventilator whenever the patient's intubated, whenever you would use a BVM, and then some other examples, some things like pneumonia, ARDS, COPD, asthma exacerbation, more so when a patient's having a severe respiratory issue, respiratory complaint, and that they aren't able to manage by themselves, that you've been trying everything that you can up to this point to manage, and it's just not really working out. So you're going to go ahead and get this patient on a ventilator, whether you do RSI, DSI, and intubate them, or you throw them on something like BiPAP, you're going to get them on a ventilator. And then finally, we have sepsis and stroke. Just this patient is not able to maintain their own airway, and so you have to use your ambu bag, your BVM, bag valve mask, to maintain their airway, to oxygenate, to ventilate for them. And like I said before, if you're going to bag this person, use your BVM, you can go ahead and throw them on a ventilator. So something to look out for when you throw somebody on a ventilator is ventilator-associated pneumonia, and this will typically start occurring within about 48 hours after intubation. Just fluid's going to start building up and causing an infection in the lungs. But you can mitigate this by using some proper oral care. And then just a quick fact, 250,000 to 300,000 cases of ventilator-associated pneumonia happen every year. And so when we're looking at oral care, what does that mean? What are we doing? So we're going to go ahead and start suctioning the patient's airway for secretions every 1 to 2 hours or more as needed. We're going to go ahead and place an NG tube just so that the stomach contents can't come back up and out. Brush the patient's teeth every 12 hours or, break that time up, maybe do every 3-6 hours, just as needed. But a minimum of 12 hours. Every 12 hours, brush their teeth. We're going to go ahead and apply moisturizer to the patient's lips every 2 to 4 hours, and then clean the patient's mouth out with a chlorhexidine swab twice a day at a minimum. So when we use a ventilator, there's calculations that we have to do to make sure that we're going to be giving the patient a safe amount of air into their lungs. And the way that we're going to use those calculations, we're going to use the patient's ideal body weight. And so ideal meaning that this person could be 6 foot, but if they're 80 pounds, they're going to get the same amount of air volume to their body that somebody who is 6 foot and 250 pounds, because their organs, their lungs are going to stay the same size because they're both at that 6 foot height. And so they're going to be about the same size. And so we want to go off of their ideal weight and not their current body weight. And there's a couple different formulas that we're going to use to calculate it, one for women, one for males. The first one is going to be for every inch above 60, so every inch above 5 foot in height, 5 feet in height. We're going to multiply that by 2.3, then add 50, and that'll get the ideal body weight in kilograms. So we can go ahead and look at the first one, a 5'10" male. So 60 is going to be that 5 feet. And then everything after that is going to be that 10 inches. So we're going to do 10 multiplied by 2.3, and that's going to be 23 plus 50, and that's going to get us to 73 kilograms. For women, you're going to go ahead and use their ideal body weight formula, and not much is going to change except for the second half of the equation. So we're still going to do every inch above 60, every inch above 5 feet, multiplied by 2.3, but now we're going to add 45.5, and that'll get you to about the patient's ideal body weight. So example for the women, 5'4" woman, we're going to do 4 multiplied by 2.3, and that's going to be 9.2, plus 45.5, and that'll get us to 54.7, but we're just going to go ahead and round up and say that they are 55 kilograms. All right. And then we have our formulas for our kids, our pediatrics. To find out their weights, we can use the Broslow tape, or you can ask the patient's parents for an accurate weight. But a Broslow tape will probably get you a little bit closer to what that ideal would be for that kid. But we also have formulas for them. And so the infant formula for 12 months and less of age, you're going to do age in months plus 9 divided by 2, and that'll get their ideal weight in kilograms. So a 9-month-old, 9 plus 9 is 18, divided by 2 is 9, and so that'll get you about 9 kilograms, or that patient's ideal body weight. For children between 1 to 5 years old, it's going to be 2 times their age plus 5, and that's going to be their weight in kilograms. So a 3-year-old, we're going to start with 3 plus 5, their age plus 5. That's going to equal 8. And then we're going to multiply that by 2, and that'll be 16 kilograms. And then we have children 15 to 14 years old. And the reason it stops at about 14 years old is because at 15, we're going to start treating kids like an adult. Or we're going to do 5 up until puberty age, and then that's when you start treating them like an adult if that kid has hit puberty. But 5 to 14 years old, what we're going to do for them is age in years times 4, and that'll be their estimated weight in kilograms. So an 8-year-old, 8 times 4 is 32, so 32 kilograms can be roughly what you can expect for their ideal body weight. So now we're going to go ahead and talk about lung capacities with our ventilators. And so these are just some terms that are going to be good for you to know. The first one is going to be inspiratory reserve volume, IRV, and this is going to be the biggest breath that you can take. So regular breathing, these smaller lines here, and then you see it shoot up for the biggest breath in that you could take. Then we have expiratory reserve volume. That's going to be as much as you can exhale. And so you see as much as you can exhale down here. And you might be curious why it's not going down further into this green area. And that's simply just because it can't. Down here in this green area is going to be your residual volume. And this is going to be dead space, or the non-collapsible structures in your airways, such as your trachea and your bronchi. You just can't collapse those. They are always going to be filled with air, even if you exhale as hard as you can. Those structures are not going to collapse, and so that's why you can't exhale down into this green section. And then we have our vital capacity, and this is all of the air that you can move in and out. And so as much as you can inhale, as much as you can exhale, and then your regular breathing, that's all going to be counted as your vital capacity. Some ventilator settings that you're going to have to know. VT is probably how you're going to see it on your ventilator, and that's just going to be tidal volume. This is going to be the lung volume for ideal body weight to prevent ventilator-induced lung injury. And that's why you need to know the patient's ideal body weight so that you can calculate what their tidal volume should be. The next one is going to be frequency, or F, and this is just going to be the respiratory rate, or the number of breaths the patient is taking every single minute. The next one, we have the I to E ratio, or the I time, the expiratory ratio, inspiratory, expiratory ratio. All of this is just going to be the seconds for inspiration to exhalation. And then we have our FiO₂, or our fraction of inspired oxygen, and this is going to be the percentage of oxygen. And remember, room air is going to be 21%, so if you have a ventilator that's not attached to oxygen, it's going to show up as 21%, or 0.21. Some other things that you're going to see on the ventilator is going to be PEEP, positive end expiratory pressure, and that's going to be 0 to 20. This is going to be the lowest lung pressure at baseline. You're going to typically start at about 5-ish, 5 to 7, and then increase by 2 as needed, and we'll talk about it a little bit later, the as needed part. And then we have peak inspiratory pressure, or PIP. This is going to be the highest amount of pressure in the lungs received at any point. And so you could see it right up here. just you breathe in as deeply as you can. Right at the end of inhalation, you do a slight minor exhale, and then that's when you stop and you have your P-plat. And P-plat is going to be plateau pressure. This is going to be airway pressure during the end of inhalation, measured during an inspiratory hold. And so you take your deep breath in, you don't hold it all, you let just a little bit out, get your P-plat, and then you exhale. And that's it. So some more basic ventilator settings. We have our vent settings on the left, and then the normal ranges on the right side. So for tidal volume, VT, you're looking at about 4 to 8 cc's per kilogram. And again, that's going to be based off of the patient's ideal body weight. Then we have our frequency, our rate, and that's typically going to be about 8 to 20 a minute. We have our minute volume, or VE, and that's going to be frequency multiplied by tidal volume, and that'll typically be about 4 to 8 liters. The I to E ratio, that's going to typically be 1 to 2, 1 second inhale, 2 second exhale. FiO₂, 21% to 100% oxygen, 0.21 to 1.0. Peak inspiratory pressure, or your PIP, you want to see that less than 35, and the plateau pressure, you want to see that less than 30. And the reason you want to see these less than 30 is because that is what's going to do the least damage to the lungs. As you start getting higher than that, you're going to start causing barotrauma to the lungs, and so you want to keep those pressures at that or lower. So now let's go ahead and talk about our ventilator modes. The first mode is going to be CMV, and typically CMV is not going to be used, especially not pre-hospitally or just outside of the hospital in general. And that's just because the patient needs to be heavily sedated, apneic, and or paralyzed for CMV to be comfortable for them. Because all of the breaths are going to be triggered and set by the ventilator. So whatever numbers, frequency, tidal volume, all of that stuff, everything that you set in that ventilator is what's going to be gave to that patient, and they're not going to be able to breathe outside of what you have set. And so again, the patient will not have any ability to initiate breaths. And then we have AC, or assist control, and you will start seeing this and everything else that I'm about to talk about next. So with AC, the patient can trigger a breath, or a preset breath will occur. And so if the patient triggers a breath, it's going to be delivered at the set tidal volume that you have set in the ventilator. So if they want to take just a little small breath, they're not going to be able to, because as soon as there's a pressure change in that system, in the ventilator system, and they feel any type of inhale, it's just going to deliver that full breath that you have set, that 350 mLs of air, that 400 mLs of air, whatever you have set for the ventilator, it'll give. And so this one here typically is not going to be good for flights or if you're riding in the back of an ambulance, just because every little bump, every time the patient makes any type of sound or tries to make any type of sound or sucks in at all, that full breath is going to be gave to that patient. And so every single bump, you're going to be giving that full tidal volume to that patient, and that'll start damaging the lungs and causing barotrauma or breath stacking. But you will typically see AC started for patients that have respiratory distress, and we'll start them there. Next one, we have control volume. This is going to be based off of the tidal volume. You might hear people call it tidal volume. You're going to preset the tidal volume that will be delivered to the patient. And then once that volume is gave to the patient, an exhalation is going to start to occur. So the volume is going to be consistent breath to breath, but the pressure will be monitored because the pressure is what's going to be changing. And so if that volume just continues to increase within the lungs, it'll start changing up those pressures and making those pressures higher and causing that barotrauma, or just start damaging the lungs from that higher pressure. The next one, we have pressure control. And so you're going to preset the inspiratory pressure that's going to be delivered. Once that pressure is achieved by the ventilator, so it's just going to send air into the patient's lungs until it arrives at the pressure that's set, the pressure that you set. That's when it'll stop and let you exhale. So the volume of each breath is going to be dynamic, and it's going to change for each breath. And so we're going to have to monitor the volume and make sure an adequate volume is being gave to the patient. So the next one here is going to be SIMV, and this one is going to be the most ideal for patients. On average, it's going to be typically what's used for patients, because you're going to go ahead and preset the tidal volume and the frequency, but the patient will be able to get or take spontaneous breaths. And so they're going to be able to take as many small or as many big breaths as they can, and they're going to have full control of how much air they're going to suck in during each breath. If they just do like a little gasp and just do a real small breath, then they're just going to get a real small bit of air. If they want to do a real big breath, they're going to get as much as they want to suck in. And so this is going to be preferred for patients with an intact respiratory drive. And it's going to ensure that the patient receives the proper minute volume because you have your presets in there. So if the patient's respiratory drive doesn't kick in, the ventilator, which you have preset, will take over and deliver those breaths at the amount and volume that you already set. This is going to be similar more so to BiPAP. And on most ventilators, you have to go into SIMV mode first, and then there's a button or two that you click to get into the BiPAP mode. And so that's going to take us to our CPAP and BiPAP mode. And again, they're going to be similar because all breaths are going to be spontaneously controlled by the patient. And so with CPAP, continuous positive airway pressure, that's what that stands for. And then BiPAP, bi-level positive airway pressure. CPAP, you've probably seen these pre-hospitally. It's just a tube that's going to be plugged into the oxygen tree. And then you have a mask that you strap tightly to the patient's face. And now you can do CPAP and provide that continuous pressure to the patient. You don't need any real fancy equipment for CPAP itself, but for BiPAP, for what's preferred, you are going to need a ventilator to provide the BiPAP to the patient. And then down here, we have like a real quick tip. Clamp the ET tube when transferring from one ventilator to another so you don't lose PEEP. And so if you aren't going to be taking the facilities ventilator and you're going to use your ventilator, it is recommended just put one of your clamps on the ET tube, disconnect the hospitals, plug yours on, then disconnect your clamp, just so that the PEEP, the patient's lungs, remain inflated and we don't deflate them, causing more trauma. And then our last ventilator mode is going to be PSV. And this is going to support the patient's ventilation during inspiration, and it's going to add just a little bit of back pressure to the patient as they're breathing in. The patient's going to be able to determine their tidal volume and their rate, so they're going to have an intact and consistent ventilatory effort, respiratory drive. This is typically going to be used to kind of wean the patient off of the ventilator and kind of strengthen up their lungs before we completely disconnect the ventilator and monitor them. And so this is going to be somebody who's been on the ventilator for weeks, months at a time, and now they're going to be spontaneously breathing. We're going to put them on this just to assist, just to strengthen up those lungs, and then take it off, monitor, and then hopefully discharge is going to be what's happening soon. All right, so we've talked about the ventilator for a little bit. We've talked about different settings. Now let's go ahead and look at some common problems. And the first one is going to be auto PEEP or air trapping, or just not enough exhalation. You're going to have to measure this on your ventilator. It's going to be a little bit different. The steps are going to be a little bit different on each ventilator. But you're going to do the expiratory hold maneuver on the ventilator after exhalation and then prior to the next breath. And that's when you're going to start looking for those numbers. Air trapping, breath stacking, this can all occur when the patient is spontaneously breathing, and that'll start causing barotrauma. So this is something that you will actually be able to see on the ventilator. Depending on the type of ventilator you have, there might be a graph or some bars that you'll see pop up across the screen, and you'll start seeing the patient start to exhale and then take in another breath, and so that exhale will shoot right back up, and then it'll start looking like stairs going up. And then we have PVD, patient ventilatory dysynchrony, and this is just going to be the patient's respiratory demand is not being met, and so there's either a problem with the ventilator settings, or the patient is not properly sedated, or their pain's not being managed properly. And so now you're going to start seeing kind of those anxiety-like symptoms. And this can even happen if you have the patient paralyzed but not properly sedated. So you're going to start seeing that hypertension, tachycardia. They're going to start breath stacking. Alarms are probably going to start going off on your ventilator. And the patient's just going to appear as if they are in distress. And if you just can't figure out another reason why they're in distress, it's probably going to be PVD. And so we either need to sedate and or start changing our ventilatory settings, our ventilator settings, to meet the demands of the patient. With ventilators, with oxygenation, ventilation, or just simply managing the patient's airway, you've probably heard of a mnemonic called DOPE. And so what it's going to stand for is dislodge, disconnect, obstruction, pneumothorax, or equipment failure. And so when the patient is on a ventilator and you're seeing a low pressure alarm, we're going to start thinking that something got dislodged or disconnected between the patient and the ventilator to the patient. So we're going to start checking those things, ensuring that everything's still connected and working appropriately to help mitigate this low pressure alarm. With your high pressure alarms, you're going to start thinking that there's an obstruction, a kinked tube, or you need to suction out that tube, the ET tube, and that's going to be what's causing your high pressure alarm. So you need to start working on and fixing those things. What you can do with suctioning of the tube, especially after those ET tubes have been in for quite some time, you can start squirting just, 3 milliliters about at most of saline into the ET tube, and then suction it out to break up that mucus that's being built up in that tube. Another reason for a high pressure alarm is going to be a pneumothorax, and that's going to be a very critical one. So when you start seeing the high pressure alarm, you need to act on it immediately. Rule out these things, the less severe things, so that you can move on to the more severe thing, that pneumothorax, as being the reason for the high pressure alarm, to get things mitigated. And then the last thing is just going to be equipment or ventilator failure. And so if you have these alarms going on and you've tried everything that you can think of, everything that anybody else can think of, and just nothing's working, the patient is still in distress, these alarms are still going off, what we're going to go ahead and do is we're going to switch the patient from the ventilator and put them on a BVM, an ambu bag, BVM, bag valve mask, and we're going to start breathing for this patient with that bag. And if there's any resistance as you're breathing for them with that bag, then we can heavily start thinking that it's an ET tube issue or it's a patient lung issue, meaning that there needs to be a new intubation attempt, or there needs to be a review for a possible pneumothorax. But if you're bagging the patient and everything's fine there, then we're going to start thinking there was an equipment failure elsewhere with the ventilator or with the tubing, and so we're going to start changing that stuff out to start ruling out what the problem might have been. So some setting alarms. I know we just got done talking about high pressure, low pressure alarms. With these alarms, you're going to be able to set them yourself with your ventilator. And so the high pressure alarms, you're just going to set it to 10 above your peak inspiratory pressure. And so with your peak inspiratory pressure, you're going to just find the average, because it is going to be a dynamic number. And so we're going to find the average of what we're seeing. We might see anything from like 34 up to 37, 38. And so we're just going to take the average or the middle number at that maybe 35, 36, and then go up 10 above that when we're setting our alarm. And so our alarm is going to be set at about 45, 46. So then with our low pressure alarm, we're just going to find what our average PIP is, that same 35, 36, whatever that average number was for us, and we're just going to set it 5 below, and that'll give us our low pressure alarm. And then we have our low minute volume alarm, and we're going to set that 20 to 25% below the patient's baseline minute volume. All right, so we've went ahead and we talked about all these different ventilator settings, all these different calculations, and so now you're curious, how can I improve oxygenation? And so we're going to start by ensuring our FiO₂, our frequency, and our tidal volume are all within normal limits. If they aren't, then go ahead and get them into those normal limits. Then we're going to go ahead and start increasing our PEEP and we're going to increase it by 2 every 3 to 5 minutes. And you're going to wait 3 to 5 minutes just to allow yourself time and the patient's time to adjust to those settings and see if any changes are going to be needed later. But remember, you can only have a max PEEP of 20, so use caution depending on the patient's ventilatory necessity. And then we can start looking at the FiO₂, increasing that. We can go ahead and increase the rate, and then we can increase the tidal volume, and then we can increase the I to E ratio. This will be the last thing that you would want to change. Use caution as it will improve oxygenation, but it will decrease CO2 clearance. So again, depending on why the patient's on the ventilator, they might need an increased CO2 clearance. So some ventilator pearls are things to keep in mind with the ventilator. The gold standard for oxygenation is going to be monitoring SpO2 levels. The gold standard for ventilation, for monitoring ventilation, is going to be capnography. So get end tidal on the patient. Every intubation, you should be utilizing end tidal monitoring. And then it is preferred to get a chest x-ray just to confirm the placement of the tube. And you're going to look for the distal part of the tube, the end of the tube, to be about 3 to 7 centimeters above the carina. For pediatrics, you're going to look at the end of the tube being 1.5 centimeters above the carina. And we can go ahead and look at this picture here. We have the tip of the tube and then the carina where it divides into the bronchi. And you can see it's about 5 centimeters away. But it can be as far as 7 centimeters away and as close as 3 centimeters away. You should see the end of the tip at the T2 to T4 level, as the carina is at the T5 to T7 level. And then remember to think of the ventilator almost as a BVM. So if you are going to use a BVM on a person, you can use a ventilator on the person. If the ventilator is not working for that person, you can use the BVM to breathe for that person. And then the last thing here is once the patient is on the ventilator, allow about 15 minutes, then obtain an arterial blood gas just to ensure that the patient is truly tolerating that ventilator on a physiological level. And then in a perfect world, you're going to go ahead and get an ABG every 15 minutes during your transport just to ensure that your settings are still appropriate for that patient. And so that's it. We are not going to do a skills demo or a skills practice, but if you have any comments, questions, concerns, leave them down in the description below. But that's it for this video. Thank you for watching. Bye.